For nearly a decade, I've cared for those hidden in the shadows of our cities. As a physician that treats people experiencing both homelessness and mental illness, I've learned the importance of connection from those who often remain invisible to the many who pass by on the streets. I work for the University of Florida Psychiatry and Sulzbacher, which is a homeless shelter in downtown Jacksonville, Florida, that has a health clinic on site. I treat severe and persistent mental illness, things like severe depression, bipolar disorder, and schizophrenia. While I may see patients in my office, like typical psychiatrists do, I also practice street psychiatry. I go out into the streets to find people experiencing homelessness wherever they may be, whether that's in alleyways, under bridges, or in the woods. When I share about my work in social circles, the question I get asked the most is, should I give the person on the street corner money? During this talk, I'll explain how surprisingly, what can be even more helpful for the both of you is taking the time to get to know their name. Regardless of where you are, homelessness has gotten to the point where it's hard to ignore. Take Alachua County, for example. In January of 2024, there were 644 people experiencing homelessness and 1,247 where I am in Northeast Florida. There are many reasons people may experience homelessness. Poverty, health problems, and escaping violence are just a few. One notable reason for homelessness is a lack of affordable housing. Even for those working multiple jobs, affording a rental unit can be challenging. To afford the average two-bedroom apartment in Central Florida, working 40 hours a week, the household would need to earn nearly $26 an hour. However, many low-income workers earn minimum wage, which in Florida is just $13 an hour. Taking the time to understand why people experience homelessness makes us realize the possibility that this could happen to anyone, regardless of who we are. In fact, there's a popular saying that anybody could be one paycheck away from homelessness, but nobody is one paycheck away from being a millionaire. Often we have the idea in our head of someone experiencing homelessness as an addict, crazy, or a social misfit. But after working for years on the streets of downtown, I've come to realize we have much more in common than we think. The prevalence of chronic substance use in our local census of homelessness was 13.3%, compared to the general population of 8.1%. And severe mental illness was 14.8%, compared to the general population of 4.1%. While these rates are higher than the general population, it still suggests that over 85% of people experiencing homelessness don't have a severe mental illness or substance use disorder. The majority of people experiencing homelessness are very temporarily without housing, just doubled up, couch surfing, or paying to stay in motels, and are very much like you and me. I've even had medical students that I teach share with me that they've lived in a homeless shelter growing up. In fact, 30% of those experiencing homelessness are families with children, so it literally could be anyone. Rather than seeing the person on the street corner as other, we should instead see how much they have to offer our communities. We're more alike than we are different, and befriending our neighbors without homes can improve our own lives as well. National Geographic research on blue zones, regions of the world where people live longer and healthier lives than average, shows that people with more social connections thrive in later adulthood. When I learned about this data, I immediately thought of Veronica, one of my previous patients. Veronica was outside at a local park sitting downcast on a bench when Karen passed by. Karen, a recently retired teacher, was having a hard time adjusting to solitude. When she saw Veronica, Karen's teacher's instinct picked up on a sense that she may need someone to talk with. It turns out, Veronica had lost her phone and was desperately trying to get to a bank. She was fleeing domestic violence and didn't want her ex to access what little bit of money might help her stay in a motel for the week. Karen let her use her phone and realized she needed more than just help with the bank, so she made plans to bring her to Sulzbacher to access mental health care and case management. As I worked with Veronica over the coming months, I witnessed the blossoming of a long-lasting friendship that not only helped Veronica find stable housing, but Karen found a new sense of fulfillment in her recent retirement. Karen would share with me in the waiting room that bringing Veronica to her health appointments inspired her to take care of her own health, and it helped her break the feeling that she didn't have value in her older age. After 30 years of teaching and raising her own children, Karen once again realized how capable she was of making changes in others' lives. Karen and Veronica highlight the fact that the need for social connection is deeply rooted in our biology. Social connection not only helps us survive, but has led to human innovation throughout history. In fact, human connection is so powerful, it's been used to treat psychiatric illness since the Middle Ages in a tiny town of Geel, Belgium. In the 7th century, there was an Irish princess named Dymphna whose mom died, and Dad insisted she marry him. Instead, she fled to Geel, but her father sent his soldiers, who beheaded her. She became the saint of mental illness, and pilgrims flocked to the city, so much that by the 14th century, they built an infirmary, but it quickly ran out of room. So what did they do? The local families invited them into their homes as boarders. They've continued this practice for over 700 years, and rather than being seen by their diagnosis, boarders are seen as regular guests in the community. This history contrasts that of the US. In the early 1800s, Benjamin Rush and Dorothea Dix convinced the public that people with mental illness needed treatment and not punishment. They traveled the US, convincing states to build therapeutic asylums. However, by the 1900s, with no cure to be found, asylums became overrun, and conditions were compared to that of concentration camps. So in 1946, the National Institute of Mental Health was created. Then quickly, in 1952, the first antipsychotic medication was developed, along with the diagnostic manual that clinicians use to diagnose mental illness. So now we finally had a way to diagnose and treat severe mental illness. With the civil rights era movement towards autonomy, President Kennedy decided to close asylums and move care into communities. Unfortunately, the money promised by President Kennedy was diverted to the war in Vietnam. And we wound up with all the people who had been in asylums now either incarcerated or on the streets. While not all people who experience homelessness have a severe mental illness, this was the case for Tim, who could be found on the street corners downtown shouting at people passing by about the secret government conspiracy he had uncovered by tracing lines in magazines and newspapers. One day, his former college buddy Jesse passed by and couldn't believe his eyes. Until a few years ago, Tim had been an investment banker, and the two had regularly played tennis together along with a group of friends. Jesse rallied the tennis pals, and they all convinced Tim to seek care at Sulzbacher. When our primary care doctor completed a thorough workup to show that nothing else medical had caused the sudden change, his friends dragged him to my office, trying to convince him to accept psychiatric care. I'll never forget their visits, often punctuated with heroic stories of past tennis matches or tales of their college escapades. Jesse convinced multiple friends to come with him to the visits, which regularly turned into group therapy sessions, as they all tried to convince Tim that the secret government conspiracy was not real and that he needed to take medications. Fortunately, along with a case manager, they were able to help him get access to housing and get his retirement benefits. Unfortunately, he never did agree to medications, including when he ended up with heart disease that took his life prematurely. But to hear their stories again at the funeral was a testament to how much the friendship had strengthened in their time helping Tim. Each of them spoke about how stepping outside of themselves to help Tim had brought them so much joy and fulfillment, as if they had created their own little Geel right at home. Tim's premature death is unfortunately quite common among those experiencing homelessness, as the average age of death is 28.3 years younger than those in housing. But the premature death that homelessness causes is just one of the many costs of homelessness in our communities. Because people who are uninsured are less likely to access primary care and address health issues early, health issues are exacerbated. Ultimately, people who are uninsured and on the streets cycle in and out of crisis and inpatient health systems, resulting in high community costs but limited improvements in health. One study in Central Florida, looking at 107 individuals experiencing chronic homelessness, estimated community costs at over $31,000 per person per year, for an annual total cost of over $3.3 million. But providing those same people with appropriate housing and services would cost just 1/3 of that, around $10,000 per person per year. One particularly expensive solution to homelessness in the United States is incarceration. The US makes up 4% of the world's population, but 25% of the world's incarcerated population. There are 2.3 million people incarcerated in the US right now. But jails and prisons notoriously don't provide adequate mental health services and are associated with worsened psychiatric symptoms. Why is this relevant now? Last summer, in June of 2024, the Supreme Court upheld that arresting people for experiencing homelessness does not violate the Constitution's ban on cruel and unusual punishment. Cities across America are right now deciding how this affects the policing of those sleeping on the streets. The state of Florida enacted a law on October 1st, 2024, that bars people from sleeping outdoors and allows private citizens the right to sue cities if they feel the law isn't being adequately enforced. But there are effective alternatives. I work for Sulzbacher's MHOP, Mental Health Offenders Program, with multiple partners, including the city of Jacksonville, multiple legal systems, and managing entities. We were able to identify people who'd been arrested multiple times and have a severe mental illness. Then they provided us funding to get them out of jail and wrap them in services. Clients receive an intensive case manager, a peer specialist, and I can go out to find them wherever they are and bring them psychiatric care. Once we've helped connect them to permanent housing and income, they can graduate, which means their charges get dropped, but they can keep receiving our care. Now entering its 4th year, MHOP has been shown to decrease days spent in jail and overall jail stay costs significantly each year. Believe it or not, paying for all that staff, temporary housing, and various services is still cheaper than continuously rearresting people. But even more important are the changes in people's lives that help them reintegrate back into society. We've had nearly 30 graduates of the MHOP program, and now with stable access to housing and food and a cleared background check, many have gone on to get jobs, get their GED, and work on higher education. We've helped reconnect clients with loved ones, whether it's parents and siblings or children and grandchildren. But largely, the work we've done has made community for them. That is, a place where they can flourish. And each of the staff has had their own metamorphosis as well, as the work we do changes us for the better, including me. I remember a few years ago, my local church had a woman who regularly attended services, but then began sleeping in the doorways after hours. Many were scared she might do something to church or people going by, and they argued about building fences or calling 911. They ended up reaching out to me to see if I could help her through Sulzbacher. I remember Diana was the most polite person I've ever worked with. I've never been called ma'am so much in my life. She gladly accepted help, and over the months working with her, I learned she had served in the military. And when her siblings died, she ended up on the streets due to her severe mental illness. By treating that, she was able to follow through with all the steps needed for the VA and Sulzbacher to get her into housing, although it still took several weeks while she waited on the streets. In our work as physicians, we're taught the importance of boundaries, that keeping the patient the focus of treatment is cornerstone. We should never try to impart our own life on theirs. So we're taught not to share any personal information, not to accept any gifts, and in some training programs, they're taught not to allow for any affection. But Diana taught me more than any training program had about what healthy boundaries really are. As she became more integrated into the church community, Diana saw that I lived very close to the church and showed up one morning asking for help getting to Sulzbacher. Even though I was startled, I quickly helped her to a warm cup of coffee and drove her in with me. Over time, I ended up sharing several cups of coffee with her on the way into work. And I learned that sharing my life with her didn't impede her treatment. In fact, it helped her gain a new social network. She was included in church events, and once in her new housing, my family and other church members would visit her on holidays. Over the years, we formed a very close connection and went through her peaks and valleys together. I learned I didn't need to be so closed off to my patients, that keeping the patient the focus of treatment doesn't mean that they can't learn about me and my life while I learn about theirs. And when Diana had a recurrence of her cancer, my husband and I were able to help her navigate the hospital and hospice and bring her favorite treats. Diana showed me the beauty and strength found in true community. And she taught me that some of our most therapeutic work as doctors can occur outside the boundaries of our clinics. She also taught an entire church congregation the importance of having a morning cup of coffee with someone on their doorstep. Taking the time to get to know the name of the person on the street corner can change both of your lives for the better. Because once you know their name, you begin to see them as a neighbor with no home, rather than a nobody. This could not only help connect them to the resources they need to get out of homelessness, but along the way, you might find your own life changed as well. And although this change could lead to heartache, it is most certainly worth it for such a powerful metamorphosis for the both of you. As Gregory Boyle says, you don't go to the margins to save or rescue or even to make a difference. You go to the margins so that the folks at the margins make you different. Thank you.